Strabismus squint course for the undergraduate Ain Shams University Faculty of Medicine, third part. The type of strabismus we will start with is concomitant squint. Concomitant squint is characterized by stable primary angle of deviation in different positions of gaze. When the patient looks to the right, to the left, there is no limitation of ocular motility. Types of concomitant squint are either convergent squint, as the left picture, although this child is having epicanthus, but the eyes are not aligned as indicated by the light reflex. It is central in the right eye and eccentric in the left eye. In the right picture, we have the other type, which is divergent squint. The most common cause of concomitant squint is refractive error. To understand the relation between the refractive error and the concomitant squint, we have to understand some facts about the near reflex, which is formed of accommodation and convergence and meiosis. The target of accommodation is to keep focus on the retina. In the upper part of the picture, we see the eye is focused for far object indicated by the parallel rays. In the lower part of the picture, the rays become divergent because the object gets closer. Here the power of the lens is increased according to the distance to keep focusing on the retina. While the target of convergence is to keep the image of the object in each eye on the fovea. In the right part of the picture, the eyes are looking to distant object and the object is falling on the fovea of each eye. When the object gets closer, as in the left part of the picture, the rays become divergent slightly, so the eyes have to converge to keep the image of the object on the fovea of each eye to avoid diplopia. This happens in the normal near reflex. In the hypermetropic eyes, the parallel rays with accommodation relaxed are focused behind the retina, so the hypermetropic person is obliged to use the accommodation earlier than the emmetropic eye. So there is increased needs for accommodation and increased needs for convergence, so this person is liable to have a convergent concomitant squint. This picture shows to you the concomitant convergent squint in the left one, and the use of hypermetropic glasses is correcting this type of strabismus, and this is the most common cause of concomitant squint. In myopic eye, the opposite is true. The parallel rays with relaxed accommodation are focused in front of the retina, so this person tend to get close to have a divergent rays to have the focus on the retina. When he get close, he doesn't like to use the accommodation to keep the focus, so there is decreased needs for accommodation, decreased needs for convergence, so the eyes are tending to have a divergent concomitant squint. Other reasons for concomitant squint are media opacity. Media opacity like congenital cataract or corneal opacity in early childhood represent an obstacle for binocular vision, so this person will have a concomitant squint. Other reasons for the concomitant squint include retinal pathology. The most common in children is retinoblastoma, and followed by the optic nerve tumors like glioma. If we looked at this picture, we will find that the left eye is leucochoric. Leucochoria means white pupil. The white pupil here denotes either congenital cataract or retinoblastoma and other reasons out of scope of my lecture. Here, this child is having a type of concomitant squint related to organic lesion. It is not related to the error of refraction. The clinical picture of concomitant squint, usually the age of the patient is a child, because concomitant squint results from obstacle to binocular vision. So the parents of the child are complaining of cosmetic disfigurement. When we start examination, we start by the corneal light reflex Hirschberg test. We will find that the test in this figure is central in the right eye and eccentric in the left eye. The second step in squint examination, in concomitant squint examination, is to make the cover uncover test. Here we will cover the fixing eye, which is the right eye in the picture. So the left eye in the second picture will have fixation with central light reflex, and after we remove the cover, which is uncover step of the test, we will find that the angle of deviation is equal to the primary angle of deviation. That's because there is no paralysis of extraocular muscles and no extra impulses in case of concomitant squint. So the primary angle of deviation is equal to the secondary angle of deviation. Here we find that the primary angle of deviation is equal to the secondary angle of deviation. The second result of the cover-uncover test is to differentiate between two types of concomitant squint, alternating squint and unilateral squint. If we looked at this child, we will find that in the left picture we are going to cover the central eye, which is the left eye. In the second picture, the patient take fixation to the light by the right eye. After removal of the cover in the third picture on your right hand, we will find that the right eye returned to squint. So this patient, whenever you give him the option, he is squinting by the right eye. So he is unilateral squint. Unilateral squint is important because it may denote an organic lesion in the eye. In this child, he is fixing by the right eye and squinting by the left eye in the left picture. When we start the cover test, we covered the fixing eye, which is the right eye. So the left eye took over the fixation, and after removal of the cover we find that the right eye is squinting and keep squinting. So this patient, whenever you give him the option, he can fix by the right eye or by the left eye. So this is concomitant alternating squint. The sensory effect of concomitant squint are either alternate suppression of each eye to avoid the diplopia, and this happens in case of alternate concomitant squint, or permanent suppression, and the permanent suppression is called amblyopia. It happens in case of unilateral concomitant squint. To treat a case of concomitant squint, we start by the treatment of the cause, which is most commonly refractive error. So proper correction of error of refraction is the start point. Then we care about the amblyopia. Caring about the amblyopia is by patching of the normal eye. When we patch the normal eye, the amblyopic eye start to get over and start to improve vision after correction of its error of refraction. Then we do follow up of the angle, and we do not start surgery unless there is failure of glasses. And failure of glasses means that the patient is wearing his glasses but the response is poor. If the child is not wearing glasses, this is not failure of glasses. This is failure of the family to make the child use the glasses. And there is no alternative here other than glasses. Before the age of 6 years, our target of surgery is to regain the binocular vision. After the age of 6 years, our target of surgery is to correct the cosmetic disfigurement. We have two types of surgery in case of strabismus concomitant type. The first type is strengthening surgery. In strengthening surgery, we cut part of the muscle as indicated in the left picture, and we reinsert the muscle on its original insertion. Here the strength of the muscle is increased because we have shortened the distance between the origin and the insertion. And in the right part of the picture there is weakening procedure. In weakening procedure, we separate the insertion from its original line and get it back according to the angle of squint. Here we get it back for 5 millimeters away from the original insertion, so the muscle is relaxed between the origin and the insertion, so its strength is decreased. Other type of strabismus we are going to study is latent squint. In latent squint there is tendency to deviate. This patient appears to the population that he is not having squint. He have squint whenever he is exposed to fatigue and or loss of interest, and when we make to him by examination suspension of the binocular vision. So this tendency to deviate is avoided by the strong desire for binocular vision. So latent squint happens in older age group with well-established binocular vision. Types of latent squint are either exophoria, means tendency to diverge, and esophoria, meaning tendency to converge. Latent squint can present by the following symptoms. First is asymptomatic with no symptoms, and other symptoms which are headache and intermittent diplopia and running letters and blurring of vision happens because of imbalance of the near reflex. If we took an example, the hypermetropic eye, there is tendency to use extra accommodation. Together with the extra accommodation there is extra convergence. The extra convergence is unnecessary for the hypermetropic eye and it may lead to diplopia, so the patient tend to balance this by contraction more in the lateral recti. The contraction of the lateral recti after some times leads to accumulation of metabolites and headache. Then the lateral recti tend to relieve its extra contraction, leading to intermittent double vision and running of letters with the movement of the eyes between the strained and unstrained position. And finally there is blurring of vision. The blurring of vision happens with the stop of the all near reflex including the accommodation. The test used for the latent squint is cover-uncover test and alternate cover test. The cover-uncover test, we will notice a movement of the eye under the cover. If we looked to the upper part of the picture, we will find that the eyes on the left side are centralized, but when we cover the right eye of the patient, we will find that the eye is escaping under the cover. If we performed the procedure immediately in the left eye, we changed the cover position from the right to the left, we will find that the left eye will go to escape under the cover. The upper part of the picture is considered cover test. The lower part of the picture is considered alternate cover test because we moved the cover from the right to the left eye to see the movement of the eyes together. Other way to examine the patient with latent squint is Maddox wing and Maddox rod. In both of them the idea is to separate the vision of each eye. That's to suspend the binocular vision and to make the latent squint clear for us. The Maddox wing is shown on the left picture. It is testing the heterophoria for near, latent squint for near. It is held at a distance of about 30 centimeters from the eye, and it separates the vision of each eye into arrows in the right eye and scales in the left eye to suspend the binocular vision. If the patient is orthophoric, he will see the arrows on zero. If the patient is having a latent squint, the right arrow is presenting the horizontal strabismus and the red arrow is presenting the vertical strabismus. In the right part of the picture we see the Maddox rod. The Maddox rod is used against a white spot on the far vision to see white spot in the left eye and vertical or horizontal red line in the right eye. Here again we separated the binocular vision, and with separation of the binocular vision the latent squint will appear and the patient will see the spot not aligned with the line, with the red line. Here the patient is having horizontal or vertical latent squint according to the position of the rod, and it is used for detection of the latent squint for far vision. Treatment of the latent squint is treatment of the cause, which is most commonly the refractive error, and avoid the bad habits of using the eye with extra near work or extra work in the unilluminated conditions. And there is no surgery for treatment of the latent squint. Amblyopia is entity of dysfunction which is related closely to squint and errors of refraction. It represents decreased visual sense from a structurally normal eye, or defective processing of the image by the eye that is regained to the near normal situation. The causes of amblyopia are concomitant squint, what we call strabismic amblyopia, anisometropia, which will be covered with you in the course of errors of refraction, and sensory deprivation amblyopia, or what we call amblyopia exanopsia. Amblyopia exanopsia is a Latin word. It means that this eye is deprivated from the light in childhood. This happens in case of unilateral congenital cataract, corneal opacity dating since childhood, and congenital unilateral ptosis. Sometimes the amblyopia is mixed etiology. It can be due to three types together, as in case of congenital cataract treated by removal of the lens with aphakia. Here there is error of refraction, and finally the eye becomes squinting, so this patient will be having the three etiology for amblyopia. Amblyopia also rarely happens in cases of bilateral high error of refraction in both eyes, and this is very rare. Treatment of amblyopia is based firstly on treatment of the cause. After treatment of the cause, we do the standard batching of the normal eye, as the picture on your right side show. This child is batched for the right eye. The proper time for treatment of amblyopia is before the age of 6 years, and it is better treated before the age of 1 to 2 years. Alhamdulillah, we have finished the course online for the undergraduate strabismus, Ain Shams University, Faculty of Medicine, and if there is any interaction regarding the questions or understanding some points, you can send on WhatsApp or mail, and I will respond accordingly. Thank you.